Welcome to the first of a series of podcasts on vaccine hesitancy. My name is Tom Sorell. I'm a professor of politics and philosophy at Warwick University, and together with colleagues in the UK and Germany, I'm working on some philosophical questions raised by vaccine hesitancy. One of the issues we're interested in is whether people who are unwilling to take an approved COVID vaccine have good reasons to be unwilling. In order to answer this question, we need two things: research on why people are unwilling to take the vaccine, and a standard which allows us to call certain reasons good and other reasons less good or even bad. The standard of good reasons is worked out by philosophers, but the reasons why people refuse to take a vaccine or hesitate about taking a vaccine are the topic of empirical social science research. Some of that research will be reported today by my guest, Shaun Treweek. He was a participant at an online workshop that the project held in June 2022 to review social science research into vaccine hesitancy. This podcast interview is a chance to follow up on some of the points he raised then. Links to the presentation can be found in the program notes. Hi, Shaun. May I begin by asking you to introduce yourself?
My name's Shaun Treweek. I'm a Professor of Health Services Research at the University of Aberdeen. Interested in trial methods mainly, but also in how we can reduce inequalities, and that is what's brought me to the work we're going to talk about today on vaccine uptake in ethnic minority groups.
So maybe you can give us a little briefing about that research.
Sure. So what we were trying to do with that was to look for essentially what we already know from published literature about things that affect the willingness of ethnic minority individuals to accept vaccines, and of course, particularly the COVID vaccine. And in addition, also look for things that groups have tried to try and improve uptake, things that have been tested empirically. And we knew that a lot of that literature would be non-UK and non-COVID. So a very big part of the work was to link up with UK community organisations that worked with ethnic minorities to essentially put the evidence summaries in front of them and then talk about it. Does this fit with your views? Does it sit with your understanding of what your community's views are of the uptake of the COVID vaccine, even if the evidence we are presenting to you is around attitudes around acceptance of the flu vaccine in the US by ethnic minority groups? So we did a couple of rapid reviews that got hold of what was in the literature, one on things that affect uptake, the other on things that people have tried. And then we talked for about 15 hours over a series of weeks with representatives from 9 community organisations spread around the UK. And at the end of that process, we summarised what those individuals said to us together with the evidence, and we produced 9 evidence, we call them evidence decision frameworks. It basically summarized the evidence, summarized the discussion, and then made a conclusion.
Could you tell us a bit about how you reached these minority ethnic groups?
Sure, that is a good question. We had an absolutely fantastic partner called Egality Health. So that's a small business, community-focused business that has links with community organizations working with ethnic minority groups. So they were our way in, if you like. They were the trusted partner that enabled us academics to have very fruitful discussions with individuals from ethnic minority groups. So everything went through Egality Health.
So they were a kind of gateway to other organizations. So it kind of snowballed the research toward other people that they thought would be relevant
That's right, yeah.
to
They
what
had
you were trying.
a network, essentially, of community organizations that they work with regularly, and they were able to put us in touch with them. And Egality were part of the project as well. So they were with us during all the discussions. They were with us in all of the writing and planning. So that trusted partner was very important for us. So they didn't know us, but they did know Egality. By the end of the project, I hope they trusted us too, and they felt reassured. But to start with, they didn't. And I think without Egality and that trusted partner, we would have struggled to do this sort of work in the way we did. It really, really helped.
Could you just maybe make clear when the research was done before we get on to some of the results?
Sure. Yep. So we started. It was 2021, so it was in May. Started in May. It was a 4-month project, so it was a sort of emergency funding stream, and had to be done within 4 months. So we started in May, finished it 4 months later, and then there was a bit of time packaging our findings into a report. So we actually launched the report and made all of our material available. I think it was the 1st of December 2021.
Maybe we can turn to some of the research results. There was a discrepancy, quite a significant discrepancy between take up by um, some minorities with a Caribbean origin and minorities with and a minority with African origin. Could you tell us a bit about that?
So the reasons for discrepancy is because people are different. Their perspectives, their values are different. Their beliefs, their trust levels are different. It's not surprising that the Caribbean heritage individuals had the lowest trust. That is seen in other areas too. And we'll come on perhaps a little bit later to some of the reasons for that in particular. But I think for the two groups you highlighted, Caribbean individuals and African individuals in particular, so those two broad groups, bearing in mind, of course, that Africa is a continent, not a country, that trust, I think, is an important factor there, because those very broad groups of individuals have a particular reason to be less trusting of government and the establishment, if you like, based on a previous history, if you like, of very poor experience of interaction with those organizations here in the UK.
In the case of the groups we've just mentioned, which I completely concede come from very different places and aren't to be lumped together, the question might be, even if they can't be lumped together, even if their countries of origin can't be lumped together, or the regions of the world that they come from can't be lumped together, might there not be some kind of common, quite negative experience of racism that links them, in which case um, that might be a common thread, and that might also be connected with trust.
100% correct. Yeah, I'd agree entirely with that. So I think racism and that sort of structural racism embedded within the UK is a very, very important factor. And I think you're, again, correct in highlighting that although ethnic minority groups themselves may be different and distinct, the view of other people in the country may not be as nuanced as that. It's essentially, they're different, and the way that they treat those individuals is in a way that makes them be the individual ethnic minority individuals far less trusting of society as a whole.
If you have two groups that both experience racism and they are not distinguished very well by a majority or community, um, why would their why would their level of trust or mistrust, in as much as that bears on vaccine take up, differ?
So the honest answer from the work we've done is I don't know.
Right.
I think one of the key findings we had, our key take-home messages, was that organizations that want to, for example, improve uptake of a vaccine amongst a particular ethnic group, the only way of really tapping into what are the challenges and problems and barriers is to talk to individuals from those groups. So clearly, I'm a middle-aged white Brit. I have my perspectives. So the explanation for why Caribbean individuals are less likely than people with an African background, the honest answer is I don't know. And the only way to find that out will be to ask individuals who come from those communities. I suspect that there are differences in the way, let's say, the majority population treats ethnic minority groups. So I do think there are different ways that people are treated, and perhaps amongst Indians and perhaps well, Indians particularly perhaps, but that there may be a sense that Indians have been in the UK for a while. They're seen to, yeah, contribute to society in a way that it puts them into a somewhat different place to other groups in the minds of some members of the majority population. So I do think there is certainly the opportunity, at least, to see gradations in the way that the majority population in particular treats members of ethnic minority groups. But that's speculation. It isn't something that came out from the work we were doing.
You had statistics for take up from Bangladeshis as well. Um, and would you say that that there was a 90% take up rate? Um, that seems very high.
Mm-hmm.
Would you say would you connect that with what you just said about Indians?
Possibly, yeah. So let's say yes. But one of the things which did come out from one individual who is talking in our work, who represented one of the community organizations working with South Asians, which obviously would include Indians and Bangladeshi individuals, was that people here in the UK from those communities, their view of the vaccine changed when the COVID situation in what they were calling the home country, let's say it was in India or in Bangladesh, when the situation in those countries changed. So when things in India, this person was in India, I think, was saying, when things in India seemed to be going well, there was much less interest here in many Indians in the UK in taking the vaccine because they were looking to India, not to the UK. When things started to go quite badly in India, then people from those communities here in the UK became much more positively disposed to the vaccine. So they were looking at what is happening in what the members of our groups call the home countries. So it is entirely plausible, based on what that individual was saying, that the Indian and Bangladeshi communities were looking at what was happening back home and decided, actually, I think this is now something we ought to consider more than we might have done earlier on in the pandemic.
One of the things that's suggested by what you've just said is that the status of people as belonging to diaspora communities, communities of people who have a particular origin and origin country, but who may not feel totally assimilated in the country they live in, might, you know, so to speak, join their home communities to make judgments about this kind of decision, whether to take the vaccine or not. But it sounds to me as if there's an interesting area of research to be pursued about the degree of assimilation, because some of those folks that you were saying were perceived by the majority community as having made big contributions and who might themselves be regarded as assimilated in the UK, were less hesitant, not because of what was going on in their alleged home country, but because of their feeling more at home in the UK. Would you say that's right?
Yeah, I think it came through very strongly, this link to the home country. That was their phrase, and that wasn't something I was aware of, which is why this sort of work is
Yeah.
important to talk to individuals and communities. And many people in the community organizations, different community organizations, were saying that the messaging that is used here in the UK needs to be aware of what messaging is coming from other countries, because that messaging from other countries is very important in many people's decisions. And I reflected on that myself because I used to live in Norway. So I spent 6 years in Norway and learned the language, and I felt I was part of Norway. But if I really wanted information, I went to the BBC, i.e., I went back to the home country to look what they were saying. And I don't think anybody in Norway thought I was not part of Norwegian society. So it's completely understandable to me what people are saying. You look to the home country for information that you trust because you've got trust in that information that you may not yet have in the country in which you happen to be living, even if that country, yeah, you're having a good life in that country, as I did in Norway.
I guess there's a question about whether people who are members of diaspora communities, as between Norway and Britain, uh, are comparable to diaspora communities um, of other kinds, possibly because the the degree of being treated as an outsider might be less for racial reasons or other reasons. Let's move on now to more specifically on things to do with distrust, because one of the things I noticed when you did systematic reviews of pre-COVID literature, you found, or those studies you reviewed suggested, that distrust of the NHS and distrust of government um, were important factors in hesitancy. And one of the things that struck me is, well, these are two quite different institutions. The government is one thing, and it might be, as we'll come to discuss shortly, it might be regarded as a source of official hostility to certain minority groups. But the NHS is different intuitively, at least as it seems to me, uh, uh, because its role is not to police or to exclude or to run campaigns of assimilation or non-assimilation, perhaps. So the sort of putting together of those two quite different institutions struck me as puzzling.
Yeah, and that's again, so it's a great point, and it's a great way of highlighting why it's so important to talk to individuals from the communities concerned. Is that it's equally clear to me that these organizations are different. It is not that clear to many individuals from members of ethnic minority groups, some groups in particular. So one of the community organizations we work with did a lot of work with asylum seekers, and to an asylum seeker, the NHS and the government, they're indistinguishable. So if somebody within the NHS is asking you, you've got a name and your address, where do you live, what's your date of birth, for example, what are you going to do with that? There is an expectation that at any moment the government, the police, could turn up. So that distinction between government, as we think of government, and the National Health Service, and indeed other bits of the welfare state, is not at all clear to some members of some ethnic minority groups. It is to us, but we're part of the majority population here in the UK.
Just to harp on this a little bit more, is one difference between the government and the NHS that would even present itself to folks who were newly arrived in the UK is that there's a lot of ethnic minority people working for the NHS, and the government is not associated with those folks so much. Um, and I was wondering whether that fact uh, registered with people or whether it wasn't perceived at all.
Wasn't mentioned at all. Although you're absolutely correct, is that there are a very large number of ethnic minority individuals working within the National Health Service, but it did not come up at all within our discussions. Yeah, I'd be fair to say there. And I think some of this lack of distinction between government and the health service was also coming out of the literature too, not all of which was UK. So it was a sort of general sense that people who are new or relatively new to a country don't see the distinctions that the majority population see between bits of infrastructure, government and welfare state and the health service, etc. But it didn't come up. That point you made did not come up about ethnic minority individuals within the health service.
The former UK policy, alleged former UK policy under Theresa May of advertising to illegal immigrants that they weren't welcome, and that the acceptance by people who were implementing this policy of the goal of making a hostile environment for people of these kinds. The issue that arises is whether that kind of war on illegal immigrants contributed to vaccine hesitancy in particular, and distrust of the government in that.
Yes, and it was said in those words too during our discussion. So the hostile environment policy of Theresa May's is alive and well in the minds of many members of ethnic minority communities and was contributing to decisions to not take the COVID vaccine, in the sense that it created an environment where we, the ethnic minorities, so speaking as an ethnic minority, we're not welcome. We are not welcome in this country, and that enables some members of the majority population to treat people in a particular way. We were talking about that earlier, creating an unpleasant, hostile environment for those ethnic minority individuals, which leads to a sort of poorer experience of being here in the UK, and a history of being let down. And I think that, again, one of the things they mentioned, many of the individuals in our discussions, was that the decision to not trust government or the NHS when it comes to this vaccine was not irrational, because over decades of lived experience, people have been failed multiple times by those very same organizations. So why will it be different now? Why will they suddenly have our best interests at heart?
Let's just pursue that a tiny bit there, because one reason uh, why it might not be the same in the case of COVID as opposed to other things that have been done by UK officialdom, including the UK NHS, if it's regarded as a kind of officialdom. One thing that would distinguish it is that this COVID vaccination scheme was being rolled out to the majority population at the same time as to the minority population. So um, it's not, it's not a case where the majority population didn't trust it, or it was being tested out on a minority population. Um, there was a sense in which just because it was rolled out for a majority population, a minority population that thought that they were differentially mistreated might have a different case here, because everybody was getting it, even the majority.
Just taking myself, I saw that the vaccine was available. I trust the National Health Service, more or less trust the government. So when the message came out, they take the vaccine. I don't have any particular health issues, so I was happy to accept that offer on that basis. I moderate amounts of information, but built on a trust in the NHS.
Yeah.
So if you don't trust the NHS or don't see the NHS as distinct from government, and there's an offer to take the vaccine, then it's still your decision, or the decision of the community, as to whether you accept this offer. And even if you see others taking it, it doesn't address your concern. So one of the things that came up multiple times in our discussions was a lack of discussion about comorbidities. So if I have particular health problems, nobody is saying to me, I know that you have these health problems. It's fine for you to take the vaccine. It was, the main messaging was get the vaccine. And for myself, as a member of the majority population, the message of get the vaccine was fine, because I basically trust the NHS. But that wasn't fine for many others who don't have that degree of trust. They needed more reassurance, given this particular health condition and this particular health condition,
Yeah.
that it was safe. So I think even in that situation, which, as you say, was entirely correct, it was offered to everybody in those age bands, that in and of itself was not compelling, because people had their own reasons for being uncertain about the vaccine, and those questions and concerns were not being addressed to their satisfaction. So actually, there's a great phrase that one of our participants mentioned right at the beginning when I mentioned vaccine hesitancy, and she said straight away, actually, shouldn't use vaccine hesitancy. It's not hesitancy. We're curious. We have questions. Nobody's answering the questions.
I completely see that component of having questions that were not answered and may have been waved away as maybe not relevant. I completely see that component is highly relevant. But from the point of view of the project, one of the things that we're trying to do is just sort of see whether the reasons that in fact operate with people, including all of the ones that you've mentioned, are ones that, on reflection, we would want to endorse, if you see what I mean. So it's one thing to say it's one thing to find out from people what they distrust and to make sense of their not taking the vaccine, uh, given that they're mistrustful. But it's another thing to say, well, is that a good enough reason for being mistrustful, um, or a good enough reason to even to lump together the health service with the government? For example, whether being asked to come to the UK knowing that there'll be a hostile response, that whether it makes sense in that case to say not on your life, whether that's similar to the offer of the COVID vaccine.
In other work, a little bit in this vaccine work, but some other work, we look at things that might be a challenge to different ethnic groups taking part in randomized trials. And we try and identify potential challenges and indeed potential enablers to see if we can build that into the design. And for preventive measures, so if it was something about screening, for example, there are some, particularly I think in some South Asian, let's say Indian, Bangladeshi, Pakistani, where the attitudes towards preventive measures, which of course vaccine is, are different. So from my white British perspective, the idea of having a vaccine as a preventive measure seems very sensible. That view is not exactly the same as is held by some individuals within some communities, particularly from South Asia, who perhaps have a bit more of a fatalistic view that it's not our place. It's God will decide. So the reason for not taking the vaccine in that case is a difference in the beliefs around the value of preventive medicine as opposed to therapeutic medicine. And that would be something that if we were wanting to improve cancer screening or vaccine uptake, that we would have to work with those communities to tease out how we might find some common ground with regards to the value of this particular healthcare intervention.
One of the questions that arises from the research you've done is what culturally appropriate communication of a COVID message or a preventive message should be. And that arises partly from what you've just been talking about. Can you think of a communicative practice that you've encountered that seems to you to be an example of good practice?
Well, so if we think about, if I think about some of the things that people said in our discussion, so the community organizations themselves did a lot of messaging and work. And one of the things that was highlighted, particularly amongst those working with South Asian groups, was the value of oral communication over written. So the main message may be very similar, but it is delivered orally, not written. So that in itself, for some groups, it's not that people can't read; they can read it. That's not the problem. It's just that they prefer to get information orally, and indeed they may prefer to have a discussion, and that it's very important. So amongst communities where there's much more of this sort of verbal background or history or culture, where we want to talk about things, we want to hear people say it from a messenger whom we trust, then that would be a culturally sensitive way of delivering that information. You choose, okay, we're going to have to do this, and that could be video. I mean, you can do it. Video doesn't have to be like face to face, but that it's more visual. It's more, there's a discussion. It seems like there's a discussion going on. So that would be one. And then one of the other groups, just another example, was talking about this particular individual works a lot with Islamic groups, and whether the vaccine itself was halal or not was an important question for many of the members of that community, which was not being addressed by mainstream public health messaging. So the message that in that case, the culturally sensitive message was that this vaccine is halal, and these imams in our area here they are saying that.
Last question. I wanted to ask you whether there were some urgent research questions that you think need to be addressed in the future on the basis of the research you've done up to now.
So I'll just mention two. So one, I think, is how best to routinely work with community organizations to develop ongoing, sustained, trusting relationships, so that when the next pandemic or health issue comes along, that trust is there to a much greater extent. How best to bring the health authorities and the researchers and health system government together to build on that trust, because trust is a massive challenge right now. I don't think there is a good to go ready way of doing that that's effective. So I think researching that would be useful. And the second thing I want to emphasize is the importance of evaluation. So one of the things we found was that when we were looking for things that people have used to try and improve uptake of vaccines amongst ethnic minority groups, that there was essentially nothing that had been rigorously evaluated. So that sense that, well, if we're going to try something, we need to evaluate it, and preferably we would need to evaluate it in multiple areas, probably at the same time, to see whether we get a similar effect across these regions, is important.
Shaun, thank you very much. I think we'll leave it there.